All right, next we're going to talk about decreased pulmonary blood flow defects. These are defects that cause decreased pulmonary blood flow resulting in cyanosis. We have an obstruction of the blood flow to the lungs, or you may have embryonic failures that result in no connection of right-sided blood flow to the lungs. Because less or no blood reaches the lungs, there is less or no blood to collect and carry oxygen to the body. Failure to oxygenate results in mild to severe oxygen desaturation with profound cyanosis in these patients. These patients can present with oxygen saturations of 50 to 90%. Many of these babies that I've taken care of with Tetrology of Fallot, their baseline is 60s, 70s, 80% of oxygenation. And I really can't freak out because they are not getting oxygenation. It's their baseline. It's their normal. All right, with decreased pulmonary blood flow, what's our body trying to do? It's trying to compensate for that lower oxygen saturation. So the kidneys produce erythropoietin to stimulate bone marrow, which then will produce more red blood cells. Although we have more red blood cells that are available to carry oxygen, there is no change in the amount of blood reaching the lungs to collect that oxygen. This results in an increase in hematocrit, which doesn't really improve the oxygen saturation, right? Because it's still not getting to the lungs. We may also add a little bit of oxygen to the patient, but once again, the blood isn't getting to the lungs to get oxygenated to get it to the body, so therefore it may not see a big change, like maybe 1 or 2%. Increased red blood cell production, or that high hematocrit level, leads to polycythemia. This then can result in diminished clotting ability and major insults. So these kids may have issues with surgery. They may have issues with trauma. They're going to have very sluggish blood flow. The sluggish blood flow can result in cerebral infarcts because of small clots or brain abscesses that they end up developing due to trapped bacteria that are in those small clots. Eventually, this sluggish blood flow may lead to multiple small pulmonary infarcts in these patients. All right, so this is Tetrology of Fallot. Tetralogy of Fallot is one of the most common forms of decreased pulmonary defects. This is a good picture of it. You have 4 different disorders that is going on with this patient, and you have to have all 4 of these to occur, otherwise it's not Tetralogy of Fallot. Okay, so I'll have you refer back to this picture because I have a slide with the 4 defects. This is just a diagram of some of the repairs they are going to do with Tetralogy of Fallot. All right, so this is the 4 defects that we see in Tetralogy of Fallot. They have that ventricular or ventral septal defect, so that they have that hole between the right and left ventricle. Remember, that hole could be small or it could be a complete absence of that septum between the 2 ventricles. These kids are going to have that pulmonic stenosis, so that narrowing of the pulmonary artery coming out of that right ventricle. Remember, this can also be that pulmonary valve that's dysfunctioning. They're going to have an overriding aorta. The overriding aorta is actually opening up both to the right and left ventricle. They're also going to have right ventricular hypertrophy because that right ventricle is working harder to try to push that extra accumulated blood through the heart, and it's getting bigger and bigger, which then leads to it becoming weaker and weaker. Okay. About 5 to 7% of all heart disorders or defects results in Tetralogy of Fallot. Okay. At birth, these kids may not show signs of this cyanosis, but as the defect gets worse, then we start seeing that bluish skin. We also will see that during those periods of increased need for oxygenation, crying, feeding, things like that, we could have what we call tet spells, and we'll talk about those in a minute. All right, so these kids may be cyanotic at birth, or that cyanosis may progress over that first year of life as that pulmonary stenosis worsens. You typically hear a systolic murmur, moderate intensity on your exam. They may have those acute episodes of cyanosis or hypoxia during those parts of those times when their body requires more oxygenation, feeding and crying. Okay, these are agnoxic spells or tet spells. Okay, when these kids have tet spells, they're having an increase in resistance to their blood flow to the lungs. Okay, so that means they have more desaturated blood to the body. Okay, these tet spells can lead to brain injury or death. So we need to stop them as soon as possible. And we'll talk about that here in a minute. These kids are at high risk for emboli, seizures, loss of consciousness, and sudden death. Okay. They can also have other vital organs that are not getting their oxygen they need. Okay. So what do we do when these kids are having those anoxic, hypercyanotic, or tet spells? We want to be very calm, because the calmer we are, the calmer those kids are going to be. If I'm high stressed, freaking out, or the parents are high stressed or freaking out, those kids are going to react to that and it's going to make it worse. We're then going to put that infant or that child in a knee to chest position or make them squat. Infants, we can't make squats, so we'll lay them on their back and pull those knees up to their chest. Big kids will learn to squat when they're walking around, when they start noticing they need more oxygen. We do sometimes give them supplemental oxygen as well. Remember, it's not going to help tons, but it gets a little bit there. In the hospital, we will give them morphine and propranolol. Both of these things are going to help with that blood flow. Okay. We also give them IV fluids because that's going to help offset that sluggish blood flow and help dilute it out and hopefully get that blood flowing a little bit easier. These babies will not get their surgeries until they're bigger. Okay, it could be months down the line. So we teach these parents how to deal with these tet spells because they're going to have them at home. All right, so what do we do? Well, we're going to do surgery. We're going to do complete repair. A lot of the times with Tetralogy of Fallot, they go ahead and do that full open cardiopulmonary bypass surgery. So they do whole open heart. They cut that chest open. It's hopefully done within the first year of life. But once again, it all depends on those signs and symptoms. How many tet spells are they having? How is their baseline cyanosis going? Okay, we're going to close that VSD, and we're going to resect that the stenosis that is going on. Okay, mortality rate is very low. Okay, these kids can still develop congestive heart failure post-op. Sometimes with these kids, Their one arm may not have as good pulses post-surgery. So one thing to be aware of is not to do blood pressures in that arm due to where we have moved around arteries. Okay. Another thing that we've sometimes noticed with these kids post-surgery is they can have ventricular arrhythmias. So we keep a close eye and follow them up. They're going to always have cardiac follow-up appointments to make sure they are doing okay. All right, that is it for Tetrology of Flow.